Hello everybody and welcome to CEDEES Academy. And in this lecture today, we'll be covering in brief about multiple myeloma. Now when we say multiple myeloma, in this lecture we'll be knowing about the pathogenesis of multiple myeloma and the diagnosis. The treatment is a different aspect, which probably we'll cover it during our pharmacology sessions. So let's begin with the pathogenesis and diagnosis. Now please remember that this lecture is made so that you get the maximum information in probably 10 minutes time. And it can also be a ready reckoner for your exams. I'll be covering the most important points which will be covered, which have been asked for your previous exams, whether it is an entrance exam point of view or whether it is your medical or dental normal examination point of view, your Viva point of view, as the case may be. So if you listen to this lecture for 10 minutes, I think your concept on multiple myeloma would be pretty clear. Now when you say multiple myeloma, it's basically, in layman terms, a cancer of the plasma cells. Right? When you say plasma cells, what exactly is a plasma cell? We have a lot of these lymphocytes, right? We have T lymphocytes, B lymphocytes. It is these B lymphocytes which basically, so remember the word B lymphocytes, which basically differentiate to form what is known as plasma cells, right? Now, what is the role of plasma cell in the body? A plasma cell is one which helps in the formation of antibodies. So all of us have heard about IgG, IgA, IgM, D and E and all that, right? So all these immunoglobulins are basically that is produced by your plasma cells. Now what happens in multiple myeloma? Unfortunately, there is a defective immunoglobulin formation. Defective. So all these immunoglobulins produced, they are not, they cannot function like the normal immunoglobulins. So you must have all seen this normal immunoglobulin structure, right? You have your light chains and you have your heavy chains and all this kind of stuff. And so what happens in in multiple myeloma is that you have a lot of these light chains which are basically produced in excess. And we must have heard about Benz-Jones proteins. Now they are nothing but your light chains, right? So what basically happens here is that normally whenever there is an infection, let's say in you and me, a lot of these lymphocytes of different clones get activated. So you have plasma cells which are basically polyclonal. But in multiple myeloma, it's only a single clone which basically forms these cells. And that is why it is called as monoclonal gammopathy, monoclonal hyperglobulinemia. Right? So let's recap what is it that we have learned so far. Multiple myeloma, a cancer of the plasma cell. What is a plasma cell? Which is responsible for formation of your immunoglobulins. Unfortunately here, defective immunoglobulins are basically going to be produced. Right? Now this much concept is clear. Now let's move on. What is the basic pathogenesis of multiple myeloma? Now let us say that a lot of these plasma cells, there is a proliferation of these plasma cells. Because of increased proliferation of your plasma cells, a part of these plasma cells can enter into your bone marrow, right? Enter into your bone as the case may be. And once they enter there, they can replace your normal content of your bone marrow, right? Because it's completely filled with plasma cells now. And these plasma cells in the bone marrow can also increase the formation of a cytokine called osteoclast activating factor. Okay, let me come to it. And these plasma cells also can help in the formation of abnormal immunoglobulins. Abnormal immunoglobulins. Okay, and what do each of these three arms do? That's what we will focus on. What do these three arms do? The first one is when the plasma cells in the bone marrow replace the normal components of the bone marrow, the patients will land up with what is called as anemia. That's a very important feature. And in anemia, what you have is a normocytic, normochromic type of anemia. And over a period of time, sometimes they can also land up with neutropenia or maybe even thrombocytopenia. Okay, but anemia, normocytic, normochromic. Please remember that. Now, because of the increase in the formation of osteoclast activating factor, there could be bone resorption, right? And because of bone resorption, obviously there is an increase in the amount of calcium, so you have hypercalcemia, and you have all these lytic lesions. You have multiple punched out lesions in the skull, affecting various bones. We will come to it slowly. And because of which, the patients come to you with what is known as bone pain. And I'll put a star around bone pain because this 70% of the patients, they come to you with the first symptom or the first feature of bone pain, right? So I want you to remember this extremely well. Well, let's move on now, my dear students. And what happens if there's an increase in the amount of immunoglobulins? Right? So we have learned that there is too much of proliferation of plasma cells. These plasma cells can enter the bone marrow, they can replace the bone marrow, and it can result in anemia and a lot of other factors. It can increase the amount of osteoclast activating factor, it can cause resorption, this can cause hypercalcemia and result in a very important clinical symptom of bone pain. So put a star there because it's a very important feature. Now coming to abnormal immunoglobulins, what is it that they can cause? The first thing is you heard of Benz-Jones proteins, right? So all of these abnormal immunoglobulins can probably form a small clumping and they can damage your kidney. So it can result in what is known as renal failure. This is the second important, more than 25% of the patients land up with renal failure. So keep that in mind. The second most important feature is there is suppression of normal immunoglobulins, as a result of which the patients are prone for recurrent infections. Okay, that is the second most important concept. The third one is probably because these immunoglobulins, which are produced in excess, there is a concept that is called as M spike. That is, on serum electrophoresis, when you're doing electrophoresis, you find that this M component is increased to a large way, right? This M component is increased in a large way, and you probably call it as M spike. M stands for monoclonal. As I said before, in multiple myeloma, the plasma cells which are formed are basically monoclonal. So that is why the word M there for M spike. Okay. Now what happens here is these M proteins can probably clump around your platelets, and there could be an increased bleeding in some of these patients of multiple myeloma. There is also something that is what is called as hyperviscosity syndrome. Hyperviscosity syndrome is basically what happens is there's a clumping of all these immunoglobulins again, and patients can land up with neurological symptoms like confusion, dizziness. It could also result in increased ESR and various other features. It can also affect the clotting cascade because the M proteins can hamper the normal coagulation, so it can result in a clotting problems. It can also result in what is called as cryoglobulinemia. Okay, so I hope these simple things are very clear, all of you. This is a basic pathogenesis, simply again because of an excess proliferation of plasma cells and majorly the formation of abnormal immunoglobulins, right? So when it comes to clinical symptoms, we got to think about bone pain, which is the most important one. Then we got to think about renal failure. We got to think about recurrent infections in these patients. And then another important feature is hyperviscosity. Though hyperviscosity per se is a major feature of Waldenstrom's macroglobulinemia rather than multiple myeloma, but it's important for us to keep that there. Now this is the basic pathogenesis. Besides this, let us come to a few points which have been asked for your exams before. First of all, what is the age of occurrence? The age is majorly, multiple myeloma is not seen in a younger age group. I mean, it is always above 40 years. In fact, according to Harrison, the median age is roughly around 68 years of age or so. So in an older age group. Now when I'm saying I'm talking of immunoglobulins, the most important immunoglobulin which is produced in excess is always IgG, and after IgG comes IgA. The first immunoglobulin which is produced in excess is IgG, and after IgG comes your IgA. Now coming to the bones of involvement, the first bone to be involved, which is in excess, is your vertebral column. Okay, now after vertebral column, it is going to be your ribs. After the ribs, it's going to be your skull, and after the skull, it is going to be your pelvis. Now, these are the bones in sequence, but I guess if you remember, vertebral column is the most important bone, the first bone to be involved. I guess these concepts should be pretty clear. Coming to the cytogenetic, I mean the chromosomal abnormalities, it is mostly to do with your translocation, right? So the most important one is T1114. Q13 is to Q32. So if you can just remember that, 1114 is the most important fact, this one for translocation. So let me repeat this once more. The mean age of occurrence is around 68 years. That means older age group. Okay. Among all the immunoglobulins produced, the most important immunoglobulin produces IgG, and then comes IgA. It goes in that order. The most important bone that is involved in multiple myeloma is first the vertebral column, then comes the ribs, then comes the skull, and then comes the pelvis. And coming to the translocation, the most important one is T11, 14, right? Q13 and 32. So if you remember these points, now you have learned about the pathogenesis, and you have also learned about the various diagnostic features which you got to keep in mind. Now, let's move on to diagnosis, right? How do you basically diagnose a patient if you have a doubt? Suppose sometimes questions are asked like this. A 60-year-old man comes to your clinic who is having recurrent back pain, and he's having infections, recurrent infections, let's say chest infections, because Streptococcus pneumoniae is one of the most important organisms which can cause this problem, and also which is the most important factor for infection in multiple myeloma. And they can also give you symptoms of headache and all that. So the minute you see back pain, headache, you can majorly think about multiple myeloma. Right? Now coming to the diagnosis, I think I'm already occupying the entire board here. I'll just use this part for writing the important diagnostic features. The first one is you take a full blood picture and you have anemia. That's the first one. And in anemia, as I've said, it's basically a normocytic, normochromic type of anemia. Point number one. The second one is, let's say you take a biochemical picture, and when you see it biochemically, you find that there is increased calcium, there is increased urea, and increased uric acid. All of them are the biochemical abnormalities which can be observed. The third one, there is an albumin globulin reversal, right? So there is more of globulin than your albumin. So this is another factor. Because of this fibrinogen, too much of globulins again being increased, there is an elevated amount of ESR, which could also be seen in patients with multiple myeloma. Then comes the most important features. Okay, after you have seen elevated ESR, then as I've said, you can find Benz-Jones proteins, right? Proteinuria, you can check for Benz-Jones proteins. So this is a very important factor. These are all these serum factors which can probably be checked for. After that, you go for the serum protein electrophoresis, and that is when you find your characteristic M spike, which they again usually ask for exams, this M spike. Then comes the amount of alkaline phosphatase level. Now please remember, I put a star around it. The alkaline phosphatase level in patients with multiple myeloma is normal. In some of the cases they say that it is even low, but unfortunately in some of the textbooks, especially dental textbooks, they've said that alkaline phosphatase levels are increased. Right? Now alkaline phosphatase levels are increased in multiple myeloma only if there is a chance of a fracture. Right? But otherwise, the level of alkaline phosphatase is usually normal, okay? Because alkaline phosphatase is a marker for osteoblast, not osteoclast. And osteoclast, the marker is acid phosphatase, right? So this is about a few very important factors. Now I'm going to write the most important factor, probably in a different color. I wanted to remember that, and I put a star around it. One of the most important factor is the increase in the amount of what is called as beta-2 microglobulin. Now please remember this fellow. This beta-2 microglobulin is the most important prognostic factor of multiple myeloma. In fact, there is a classification called International Staging, ISS classification, and they correlate it with the amount of microglobulin. If the level of microglobulin normally is around 1 to 2.5 milligrams per liter, but in patients with multiple myeloma, it increases beyond that. And if it increases beyond 5.5, then it is graded as stage 3 or grade 3. That means severe. Right? So what you have to remember is, more the amount of beta-2 microglobulin, the more severe the disease, and we can put it as poorer the prognosis. So more amount of beta-2 microglobulin, poorer the prognosis. So I hope these few things are what is called as your, for diagnosis, these are the serum factors. You can also have, I guess, I think I'll write it down here. We can also go in for your checking the urine, right? In the urine, you can check for the total protein count if it is greater than 1 gram per 24 hours, or you can also check for Benz-Jones proteins, right? You can go for various X-rays, skeletal. You can go for various X-rays. You can have a full body X-ray. You can check for the skull, the chest, the pelvis. You can find very characteristic multiple punched out lesions. So that is very characteristic when you're taking out X-rays, right? And you can also go on for a bone marrow biopsy. You can also go on for a bone marrow aspiration, and you can check for the amount of plasma cells. So these are the various things which you can do for the diagnosis. Let me repeat again. I don't know if I was a little fast here. When you're looking for the serum factors, you look for anemia, normocytic, normochromic, biochemical findings, that is increased calcium, increased urea, increased uric acid, albumin globulin ratio, there is a reversal, increased amount of VSR, Benz-Jones proteins are elevated. You can find them in the urine. There's characteristic, when you do serum electrophoresis, one of the first tests to be done is you find a characteristic M spike, it's a monoclonal spike. Alkaline phosphatase level is normal or sometimes low. The amount of beta-2 microglobulin could be elevated. And more the amount of beta-2 microglobulin, the poorer the prognosis of the disease. In fact, as I've said, if the beta-2 microglobulin is greater than 5.5 milligrams per liter, they say that the median survival rate as per Harrison is just around 29 months. So it's just very, very prognostic factor. Coming to the urine, you can check for the total protein count if it's greater than 1 gram per 24 hours. And check for Benz-Jones proteins. You can go for a full body X-ray to check for the various multiple punched out bony lesions, and you can also go for a bone marrow aspiration biopsy. I hope these things are pretty clear. Coming to the diagnosis. Now there are two small things which I'd like to cover. One is about there is a criterion which have certain criterion which have to be followed in multiple myeloma. And the most important criterion is what is called as a Jury and Salmon criterion. Jury and Salmon, they have classified it as major and minor criterion. Okay, major and minor criterion. Right? I think I'll just tell it out. You can probably read it in a book later, but I'll just tell out the major and minor criterion. The major criterion, there are three major criteria. One, you take a tissue biopsy. There is, you find there is plasmacytoma. Yeah, plasmacytoma. That's the first one. The second one, if you're doing bone marrow, if you're doing your bone, if you're checking for your bone, and you find that there is bone marrow plasmacytosis, which should be greater than 30%. Please remember that when one of the major criterion is bone marrow, if you're doing plasmacytosis, it is greater than 30%, right? And the third one is an M spike. So what's the first one? Soft tissue, your plasmacytoma, your bone marrow plasmacytosis, which is greater than 30%. And the third one is if you have an M spike. These are three major criterion. Coming to the minor criterion, all of you, it's very similar to the major. The first one is the bone marrow plasmacytosis. If it is between 10 to 30%. If it's greater than 30, you put it as major. Right? The first one is it's between 10 to 30%. The second criterion for minor is if you're looking for the bony lesions, if you're looking for let's say your bone marrow plasmacytosis, again this is going to be, if you're looking for your M spike, the M spike is a slightly lower level, right? Usually they say it should be lower than 3. So that is your M spike, that is your second important point for minor. And the third one is lytic bone lesions, lytic bone lesions. So these are the Dury and Salmon criterion. You can have one major, one minor criterion, or you could probably have 3 minor criterion. But the first 2 criterion is very important. Which one? The first one is that in the minor, that the bone marrow plasmacytosis should be between 10 to 30, and there should be an M spike. Maybe a little bit, lower than 3, but there should be a small M spike. So this is about the Dury and Salmon. I just remembered one small MCQ which was asked recently for exams. In multiple myeloma, you have various inclusion bodies, right? So if you have what is called as an intracytoplasmic inclusion body, you call them as Russell bodies, okay? But if you have an intranuclear inclusion bodies, you call them as the Dutcher bodies, Dutcher, D-U-C-H-A-R. Okay, so my dear students, I'm hoping that I'm just trying to make it very short so you can go through the lecture and you can remember the most important points about multiple myeloma. This is just about the pathogenesis and the diagnosis. What are the important findings whenever they give you a statement problem? For example, they tell you that a lady comes to you with a hypercalcemia. She comes to you with increased uric acid. She comes to you with let us say normal alkaline phosphatase level. So the normal alkaline phosphatase normally is around 30 to 120 international units. So then you can immediately, the first thing you'll think of is multiple myeloma. So keep these clinical pathogenesis in your mind. If you keep this clinical pathogenesis in your mind, it becomes very, very easy, and you can keep all these biochemical findings. So it will really help you to come to the diagnosis of multiple myeloma and diagnose the particular condition. I hope this lecture was useful based on pathogenesis and the diagnosis. The treatment aspect about what kind of drugs have to be given, I'll cover it during our pharmacology sessions. Thank you so much. Take care.